Hi, I'm Steve Selig, founder of Fit Test, and the topic of this short video is dilated cardiomyopathy for exercise professionals. So just first of all, a revision of what is heart failure, because dilated cardiomyopathy is a very important manifestation of heart failure. The hallmark sign is low cardiac output at rest, submaximal exercise, and maximal exercise. Using the Fick whole body formula is cardiac output times oxygen concentration difference between the arteries and the mixed venous blood. And in particular, cardiac output is low, made up of those two components of heart rate and stroke volume. In this video, I'm not going to talk about heart rate at all, or very little. And there are so many things that affect heart rate other than heart failure, including prescribed medications such as beta blockers and calcium channel blockers, that really it just confuses the issue around heart failure. And I think a really good way to think of heart failure is reduction in stroke volume rather than the total of cardiac output, which involves heart rate. Now, for the heart muscle itself, VO2 cardiac is the formula is quite similar. So oxygen demand and supply by the heart relates, instead of cardiac output, relates to its blood flow, coronary artery blood flow, times O2 arterial minus coronary artery blood flow times O2 coronary sinus. O2 coronary sinus is fairly inconsequential. And so really the three components of oxygen consumption for the heart and oxygen demand and supply, if you like, coronary artery blood flow, hemoglobin concentration, and O2 sats. They are the main components making up O2 arterial. The hallmark symptoms of heart failure are shortness of breath on exertion and even at rest, fatigue during exercise, and even at rest in more severe forms of heart failure. There's a very useful functional class system, which is really good for exercise physiologists, exercise professionals, because it really relates to exercise. And the first one is that in class 1, New York Heart Association functional class 1, they only have symptoms at high intensity exercise. And for all intents and purposes, you can treat them as if they were normal, obviously managing their risk factors and their primary presenting medical conditions and comorbid conditions. But leaving all that, accounting for all that, in terms of their symptomatology in exercise, you can really treat them as normal healthy. Class 2 have symptoms at moderate intensity exercise. Class 3 symptoms at low intensity exercise. And class 4 symptoms at rest, which means you can really only exercise them using smaller muscle groups, such as single limb or even partial part of limb, and keeping loads and movement patterns down to low levels. Now, we now get into the two main classifications of heart failure with reduced ejection fraction, or HFrEF, is also known as systolic heart failure with preserved ejection fraction, HFpEF, is also known as diastolic heart failure. Now, one of the main problems, and I'll just put this next box up to explain why blood pressure is a problem in post-exercise, in other words, recovery from exercise in people with heart failure, is when anyone goes to exercise, including people with heart failure, you have a peripheral vasodilatation going on, a reduction in total peripheral resistance. This reduction in total peripheral resistance persists for some time after the person finishes exercise. And if we then take the cardiac output side of it, people with heart failure have reduced heart rates, often due to, for example, beta blockers, calcium channel blockers, other medications, and a whole lot of other factors can dampen down the heart rate response post-exercise. So we get reductions in heart rate below normal post-exercise. Stroke volume is low because of the heart failure itself. So all of these things work in a perfect storm to decrease blood pressure to lower than pre-exercise levels in people with heart failure. And that's why I've said in the tips here, clients with heart failure are susceptible to post-exercise low BP, and the feelings of pre-syncope, faintness, feeling like they're going to faint, feelings of severe fatigue and being washed out. They can persist for hours or even, in the extreme cases, a few days. So they're really nasty symptoms, and they need to be managed. Now, if clients experience these, and I'll show you how I manage these in my case study coming to the end of this video, then if they do experience these, you need to lie them down, and that will help to restore blood pressure just through gravity, through postural effects. You need to have care with high intensity training and high intensity interval training, because they make this whole scenario a little worse. You need to step exercise up and down, and I'm going to show you that when I talk about the case study. So we're using step ups and step downs before getting to the actual exercise intensities that you're going to use. We also always need to make sure that the client has sufficiently recovered from exercise before permitting them to leave. So being careful with driving post-exercise session, sometimes making sure that there's someone at home to look after them if they deteriorate. And one of the things that I do is, if I'm worried about a client, I will ask that client to text me to say how they are feeling, maybe 2 or 3 hours after arriving home, or if they have symptoms, to text me straight away. So at least if I need to, I can make contact with the person's primary care medical practitioner or some other medical practitioner urgently to let them know what possibly is happening with that client. So just continuing on, I think these are 3 nice pictures of hearts with different, well, first of all, the normal heart shown here. This is end diastolic volume here, and then the stroke volume indicated by the thick red arrow. In the dilated cardiomyopathy, which is what I'm going to talk about in this video, we have a heart muscle which has been chronically stretched, thin-walled, poorly contracting, and because of the poor contraction, we have reduced ejection fraction, and we have reduced stroke volume here, indicated by this smaller, less thick arrow than in the normal heart. And for the hypertrophic cardiomyopathy, we have a heart muscle that's been thickened, concentrically hypertrophied. So in other words, growing inwards. The end diastolic volume is much less than for the normal heart, and the end diastolic volume for the dilated cardiomyopathy is much greater than for the normal heart. Now, the dashed line now shows end systolic volume in a normal heart, and the difference between the thick line and the dashed line, that area in there is effectively the stroke volume. And if you divide the stroke volume by the end diastolic volume, you get ejection fraction. Now, in the case of hypertrophic cardiomyopathy, they have a preserved ejection fraction. In other words, the stroke volume here divided by the end diastolic volume here looks normal, but in fact the stroke volume is low because the end diastolic volume is low and the end systolic volume is low. Everything's low, and the heart muscle, although it's contracting, it's pushing out less blood. Now, the problem for hypertrophic cardiomyopathy, which is not the main topic in this video, is in the filling of the heart, because the heart is thick and stiff, and there's a problem with filling, shown by this red arrow here. And of course, that will then manifest as reduced stroke volume on the next heartbeat. Now, if we go to dilated cardiomyopathy, which is the topic of this video, we see here that the end systolic volume is not a whole lot different to the end diastolic volume, showing that the actual stroke volume is really impaired here. Stroke volume is impaired here because of the lack of contractility of this thin-walled heart, whereas stroke volume is impaired here because of the low filling volume of the heart, low end diastolic volume of the heart due to the stiff, thickened heart muscle wall. Now, this is also shown in a sort of a similar diagram, but showing a slightly different concept. Here's the normal adult heart. Here is the athlete's heart, which is a larger variant of a normal heart. So it's just like a normal heart, but enlarged, and showing mildly enhanced cardiac function here. And then we come to hypertrophic cardiomyopathy, which is the thickening of the ventricular wall, lower end diastolic volume shown here, and I haven't shown end systolic volume in this diagram. And then here we have the dilated cardiomyopathy, which is thin-walled, poorly contracting heart with a very enlarged end diastolic volume, but not much capacity to produce stroke volume. Now, the European Society of Cardiology published these sort of guidelines on dilated cardiomyopathy in 2020. So you can get this from the European Society of Cardiology. They've provided guidelines across all of the major cardiovascular conditions that you see in cardiac rehab. And the first thing they say is that participation in low to moderate intensity recreational exercise should be considered in all individuals with dilated cardiomyopathy, regardless of the ejection fraction, in the absence of limiting symptoms such as chest pain, obviously, and other things, and exercise-induced ventricular arrhythmias. Participation in high or very high intensity exercise, including competitive sports, with the exception of those where occurrence of syncope may be associated with harm or death, can be considered in asymptomatic individuals, but they need to fulfill all of the following. So they can only be mildly reduced in ejection fraction, which really isn't what I represented on the previous slides. So we're talking about mild disease for people engaging in HIIT or high intensity interval training program. So a very modest reduction in ejection fraction here. Absence of frequent and or complex ventricular arrhythmias on ambulatory Holter monitoring or exercise testing. The absence of late gadolinium enhancement on cardiac magnetic resonance imaging. This is limited to detect diffuse. It's limited in its scope to detect diffuse interstitial fibrosis, but it is used in that sense. And it's commonly found in idiopathic dilated cardiomyopathy. So you need to have an absence of that late gadolinium enhancement in order to participate in competitive sports or very high intensity sports. You need the ability to increase your ejection fraction by 10 to 15% during exercise. So again, we're talking about mild disease, and then there is some genetic profiling that's used as well. So the criteria for participating in high or very high intensity is really restricted to those with very mild disease who are not really impaired much, and they're probably in the functional class 1 in terms of, well, certainly are functional class 1 in terms of the New York Heart Association classes for heart failure. Now, follow-up is recommended annually. You don't need to worry about that because people with dilated cardiomyopathy will almost certainly be under the ongoing care of a cardiologist and having the relevant scans done. Some people with dilated cardiomyopathies will be fitted with pacemakers, and some of them will be fitted with implantable cardioverter defibrillators. So just a little bit more about the physiology of dilated cardiomyopathy before I get onto my case study. Dilated cardiomyopathy refers to a big, thin-walled, floppy, and overfilled heart with a greatly increased left ventricular end diastolic volume and poorly contracting left ventricle, a reduction in left ventricular ejection fraction, and a reduction in stroke volume. there is the risk of pulmonary edema due to fluid accumulation in the lungs, and that's something to really consider in dealing with people with dilated cardiomyopathy. Now, I'm just showing here the Frank-Starling relationship. Now, first of all, for a normal, healthy person that is capable of running, as they go from rest with this level of ventricular end diastolic volume shown here, if we trace this green dot down to here, that's the left ventricular end diastolic volume, and that produces this stroke volume at rest. I'm not putting numbers on it, but just to illustrate the point. When they go to exercise, we get more filling of the ventricle, so end diastolic volume goes up. We're moving along the x-axis, and we're moving up the y-axis as well, the heart responding with more stroke volume. For the athlete, that's just a superior form of what I've just talked about, where instead of running at that speed, they can run at this speed with even more filling of the ventricle, but in a safe way, not at the pulmonary edema level, and the heart responds with even more stroke volume. So that's an athlete. Now, if we take people with dilated cardiomyopathy who have so-called compensated heart failure, they have, compared to the average person, they have much more filling of the heart, and they are capable of some ability to exercise, so going up to a walking pace here, but probably not ability to run. And they have some further filling of the ventricle, unfortunately, and some increase in stroke performance, in stroke volume. However, those that are at risk of decompensated heart failure, in other words, the risk of pulmonary edema, what they can do is stay on this lower curve here, and instead of moving up to get good stroke performance, they really hardly move. They hardly move in terms of stroke volume, and they're really impaired in terms of their ability to exercise. And post-exercise, they are at some risk of decompensated heart failure, which is on the wrong side of pulmonary edema. By decompensated heart failure, I mean that now the heart is failing acutely. It's really, the best way to think of it is it's an acute exacerbation of the chronic heart failure coming from dilated cardiomyopathy, an acute exacerbation. Now, that acute exacerbation may come from excessive fluid intake, which is nothing to do with us as exercise professionals, but we should monitor that they are sticking to their fluid regime. It could be the fact that they're not taking their diuretic, and they've got an acute, over several days, an acute exacerbation, and that would be manifested as fluid accumulating, say, in the lower limbs. Fluid, unfortunately, also accumulating in the lungs, which is going to cause them to have to go to hospital, usually, not always, but possibly go to hospital. And they may not have been taking their diuretic for all sorts of reasons, and that's pushed them acutely over several days, and that can be manifested as an acute weight gain of, say, a couple of kilograms of fluid gain over a couple of days. So if they're presenting to you in that condition with rapid recent weight gain, it's probably associated with fluid, nothing else, then you need to be suspicious that they're going into this form of decompensated heart failure, pulmonary edema, which is going to drop their O2 saturation because of the fluid problems in the lungs, and that's going to cause real problems, as well as they're going to be highly symptomatic in terms of being desperately out of breath and feeling like they're drowning in their own fluid. So what we really want is to go from here to here in dilated cardiomyopathy and not along this path here. So I now want to come to my case, 69-year-old female with dilated cardiomyopathy, started in 2022 with non-ischemic cardiomyopathy with MRI features of myocarditis and pericarditis. I'm not sure if this was related to COVID. And then this year in 2023, when I made this video, dilated left ventricle with moderate to severe impairment of left ventricular function, with heart failure with reduced ejection fraction. Left ventricular ejection fraction was just 31% when it should be around 55%, 50 to 55%. She had severely hypokinetic regions of her heart, in other words, regions of her left ventricle that were very poorly contracting. and particularly around the anterior wall and the anteroseptum. To help her heart failure out, she was on bisoprolol, beta blocker, that's first line for heart failure, ramipril, angiotensin converting enzyme inhibitor, first line for heart failure. Apixaban is the anticoagulant, oral anticoagulant, because of the need to prevent blood clotting in this poorly contracting left ventricle with hypokinetic regions. Those hypokinetic regions can foster the formation of blood clots, which can then travel to the brain and cause strokes or other areas of the body. So apixaban is there for that purpose, I think, not 100% sure. She's on an sodium glucose lipase transport inhibitor, which is used in heart failure quite often these days. It's not just to do with diabetes, but it's used in heart failure. Has good data on morbidity and mortality, and spironolactone, which is the mineralocorticoid receptor antagonist, first line diuretic. Now, this is what I was able to do with her. First of all, in November 2022, I was able to do a nice incremental exercise test of about 10-minute duration. Each of these dots is 1 minute, highly linear response, and a VO2 of about 21, which was not really terrible at all, not too bad at all. She was sitting in the average for all patients. And then after some training, we were able to lift her VO2 by about 8%, which is just enough to notice it. She's an ongoing client of ours, and we're hoping to obviously get more than that, but at least we got about an 8% improvement, which will be enough to make some difference to her lifestyle. And again, a very nice incremental exercise test performed using my app, myfitness.com.au. And this is the interval training that I was talking to you about before. I strongly recommend you do these step ups and step downs to prevent those blood pressure changes that are going to cause those symptoms very commonly in people with heart failure. And in this case, I did two examples, a moderate intensity interval training and a moderate intensity continuous training. You might think these don't look like moderate intensity, 80% of VO2 peak, 90%, 88% of VO2 peak. But remembering what I've done here, VO2 peak was based on a submaximal test. I did a submaximal symptom limited test rather than extending it out to the actual maximum. So these percentages are, well, first of all, here, we've got a symptom-free range of exercise intensities here and here, and we've got a symptom-free range of exercise intensities for all of these, including up to about this level here. So you can do all sorts of variations of this. In this example here, I did 3 minutes at these higher intensities and then 1 minute backing off to do some recovery. And she was also able to maintain the best part of 20 minutes, or actually this was about 10 minutes, I think, 10 minutes at this 80% of VO2 peak and stepping it up and stepping it down. Just one thing to add here, I did have a 12-lead ECG, so I was able to document a partial or incomplete left bundle branch block here. Exercise is contraindicated, but we can manage these carefully. However, you would need an ECG to identify this. She was in perfect rhythm. This was actually her post-exercise ECG. So apart from the incomplete left bundle branch block, she had perfect rhythm here. These are her blood pressure responses to exercise. I haven't got the pre-exercise or the pre-exercise blood pressure, but you can see that her post-exercise is on the lowish side, I suppose. Oh, no, it's actually not too bad. It's about 120/80. So the blood pressures are actually quite good there. Now, if you're going to do ECGs and someone has a left bundle branch block, here is a little tip for you. Although the ST segment shown here, this is the ST level pointing to ST depression, progressive ST depression occurring in V6 shown here, this is actually in error. It's completely artifactual because you cannot interpret ST segment depression or elevation or T wave or QRS. You can't interpret any of these things in the setting of bundle branch blocks, in particular, left bundle branch block. So although it's showing, it looks like there's increasing signs of on ECG of ischemia going on with increasing intensities of exercise that then are reversed during recovery, this is actually all artifact and clinically means absolutely nothing because of the left bundle branch block. So that's just a little tip for people who are doing ECGs. So that's the end of this presentation on dilated cardiomyopathy. I hope you enjoyed this. As always, if you have any questions or want to engage with me further on this topic or any other topics, you can email me on info@myfittest.com.au. Thanks for getting to the end of this video.